I'm Loren Rose. I'm an ophthalmologist in Sydney. I've got a subspecialty in paediatric ophthalmology and have a special interest in myopia in children. The incidence rate's really hard to know because we don't have enough data. That's part of the problem. But we do know it's growing, and around the world and in Australia we've seen that the prevalence has been increasing in the last 20, 30 years. So at the moment I would say we're reaching our prevalence towards 50%, which is huge, and around the world we expect in 2050 50% of the world will be myopic. The reality is that we need to go back to how children are born and what their refraction is and how that changes over time. So if I could explain that myopia is very, very rarely from birth. When you're born, your eyes are actually small, and what I mean by that is the depth or the distance between front and back of the eye is short, and that makes you long-sighted or hypermetropic, the opposite. And then as your eye grows, you lose that. But if your eye grows too much, especially when you're young, you become myopic. And then the more you grow, the more myopic you get. The point of that is that some children are getting myopic very young, and therefore their amount of myopia as adults is quite large, and we call that high myopia. High myopia is associated with other diseases, glaucoma, macular degeneration, retinal detachments are all linked to the size of your eye. And so the longer your eye is, the higher the risk for these diseases. So when we talk about myopia in children, it's actually not just wearing glasses and the progression of needing glasses, it's actually the eye health as an adult. So when we talk prevalence and incidence of myopia, we worry that it's happening earlier in children, therefore their final numbers more, and it's happening more often, which means you're going to have more of a health burden, eye health disease as an adult. So that's why it's very important to be proactive, to diagnose it early, to treat it, which I'm excited to talk about, and to then be aware that this is a public health issue. People know their grandparents were myopic, so it's been around for a long time. It's not a new disease, but what we now realise that the rate of it's increasing probably related to our lifestyle. So we know in first world countries like Australia and the US and many countries in Europe, that rate is exponentially growing, and it probably started with urbanisation. And it probably started with our education system being better or more strict. And so we know now that the confounders or the things that in our environment make myopia more common and more progressive is more time indoors, more near work, and education, which is probably the combination of those two. And so we see in poorer countries like Africa and Cambodia, where I've worked and done some charity work, they barely have any myopia. So we do blame our near work and our devices, but I'm going to say that's probably our second wave. Our second wave we will start seeing in the next 10 years, because it takes time for this change to become, well, maybe not so many years because of COVID, has become more pronounced, that indoor, near work, device use, which has become huge in the last, I'm going to say 10 years. But this started before that. This started when we started educating ourselves really well. And we see it in our studies showing it all around the world with epidemiology that if you spend more time outside, if you do less near work, we see the rates are different. We see them different in summer and winter. That's how sensitive it is to what we do with our lives. So to specifically answer your question, I think it's been around for a long time, slowly growing because of our urbanisation, but it's probably going towards a peak because we've just spent more and more time indoors, and COVID was probably a precipitator of that, even more so. The symptoms are tricky because children rarely complain that they can't see, especially when myopia you can see up close, so you just get closer. Or you lose interest. If you're in the school and you're watching the board and you can't see it, you might be distracted. So you're that kid that's not following through with the tasks that they're given. So it needs to be kind of thought about in a sideways. For example, if there's a family history. because we know genetics is important here. So if there's a family history, if a child was doing well and now's become disinterested, if they're squinting, but I'm going to say that's actually very difficult to pick up. Most children just lose interest or move on rather than complain. We do have a screening process for children between the ages of 4 to 5 in some states in Australia. That's good to pick up when vision's not good at a distance. But if it's occurring after that, you miss them. They haven't had that check. So I would say my flag to most of my colleagues or friends even, if they're myopic, they should have their children checked. And if they've had their children checked, it's really important that they have a proper check. What I mean by that is, at least in an ophthalmologist's office, we use cycloplegic refraction, which means putting drops in the eyes, waiting till the eyes are dilated, then we check the focus with lenses. Children's eyes are much more accommodating. They can change their focus, and you can over or under treat them or miss it altogether. So the best way is a cycloplegic refraction at some point. That gives you how much reserve they've got to grow. It's almost like measuring their foot and saying, this is what I expect it to be when you're an adult. And so it allows that really, really distinct measurement. That means you give them the right glasses as well. Then moving on from that, we've got, if you've got a myopic kid, you've got them in glasses. I will go back to saying that lifestyle is super important. So we talk a lot about spending time outside. The guidelines are 2 hours a day, every day, which is 14 to 17 hours a week. And I'm going to say that's the hardest thing to parents find time to do, but it's very important. The second part of that is doing less near work. Now, we don't have guidelines of hours and time, but I try and say prioritise your near work and try and minimise your near work. And near work is everything you do up close. So it is from arm's length to up here. It's not better here. It's just everything you do here. It's your devices and it's your books. So you've got to prioritise your near work because they're all the same when it comes to myopia. Moving forward, if we've got lifestyle, I'm going to say at least under control or discussed, then we're doing glasses. There are different glasses that are designed to slow down the growth of the eye. And there's a couple of glasses that have got good research that reduce progression by about 50%. And that's significant, especially when you've got a child that's very young and are going to have many years of growing. That's all accumulative. And that's what we're trying to aim for. We're trying to get that final number, not to hit the really long eye or strong power of glasses, and therefore they've not got those secondary other diseases I talked about earlier. Then there's special drops, atropine drops, which are been found now for a good almost 20 years to reduce progression. And we've got different concentrations with different, I'm going to say better effects the higher the concentration, but more side effects. So you've got to titrate that to your patient. And finally, moving away from glasses and drops, we've actually got now something called red light therapy, which is relatively new, TGA approved, which we're still finding where it fits into our treatment algorithm. Alongside with the glasses, we've got special contact lenses and night contact lenses. So as you can see, there's a whole bunch of interventions that we can personalise to your patient or to your child to then go, all right, well, maybe there's a combination here that you need, or maybe this is working now and then something else is working later. So that final number is as low as possible. Well, all professionals that look after children, it is helpful that they understand what myopia is. It also is helpful that they understand that myopia's got other interventions. What I haven't really talked about is that myopia can also be a sign of your eye not working properly, which can be a sign of something else wrong in that child's body. So, for example, we have got what we call syndromic myopia, which is myopia usually very high, but it's related to the collagen in your body. So if your collagen's not normal, you might have abnormal joints, and there are some diseases. Marfan's a typical example where it affects the blood vessels to your heart, but that also can be causing myopia because the sclera, which is the lining of the eye, is also got collagen in it. So that's just to be aware that potentially if there's something going on in the body, to be thinking maybe there's something going on in the eye. The second thing about that is when the eyes are affected, there are common syndromes that seem to affect other parts of the eye. So one of the typical places is hearing, hearing and eyes seem to be. So, for example, when I see a child that's got an eye problem, I sometimes think, well, maybe you should have a hearing check and maybe see an ENT, depending on how they present. So I suppose what I'm trying to say is the eyes are connected to the rest of the body, and although I'm very much about, myopia progression and treating them and intervening, there might be something that is actually sideways affecting them in other ways that might be important to be aware of. So when I see a child where I'm worried about syndromic myopia, for example, I will send them to the paediatrician looking for these other things.